So I had a cup of coffee in academics and very quickly learned that it wasn't the right path for me. So now instead of teaching medical students and teaching residents, I try to teach my patients. And I'm going to try to pepper some of this talk with how I explain things to my patients. It's very difficult, I think, to try to break things down into a way that patients understand, especially when we're dealing with extremely complex topics, and as well as how quickly the science is changing. So when Ann Bass approached me and asked me to talk about new developments in the treatment of neuromuscular junction disorders, I said, oh, great. So you want me to talk about myasthenia gravis? And she said, no, this is not supposed to be a talk just on myasthenia gravis. We want to hear all about problems with the myoneural junction. And I thought about that for a while, and I'll put my disclosures out here. I am on the speaker panel for both Alexion Pharmaceuticals as well as Argenx Pharmaceuticals. So I thought about it for a while, and I said, okay, let me think about different neuromuscular junction problems and then think about some of the new developments that we have in this area. So we can talk about some of the problems. So we have botulism. Now, I've maybe seen one case of botulism in my career. Of course, we're talking about starting with usually weakness in the bulbar musculature. Patients may have this odd dysphonic voice. They characteristically have the descending weakness, starting with problems swallowing, maybe problems breathing, going down to the extremities. Dilated pupils that are often fixed are extremely common. Constipation is extremely common. Not much new as far as the diagnosis and treatment of botulism. What else is there as far as neuromuscular junction disease? Snake venoms. Not very much new as far as snake venoms. I don't think I've ever seen a snake venom case. Black widow spider venom. Not much new in the realm of black widow spider venom. Tetanus. Not very much new in the field of tetanus. So, well, that was quick. So I'm going to spend most of my time talking about myasthenia gravis, but also talking a little bit about congenital myasthenic syndromes and about Lambert-Eaton myasthenic syndrome. Now, we could spend an hour on each of these topics. So this is going to be a whirlwind tour of what is new in myasthenia gravis and also somewhat what isn't as new. So let's start by talking about Lambert-Eaton myasthenic syndrome, a very uncommon condition. I've seen less than 5 of these in my career. Of course, this is a disorder that is caused by antibodies against the presynaptic voltage-gated calcium channels. It's commonly distinguished against myasthenia gravis. Myasthenia gravis is thought of as commonly starting in the bulbar musculature with ptosis and diplopia, not always. We'll talk about that in little bits later on in the talk. But with Lambert-Eaton myasthenic syndrome, really the hallmark is the predominantly proximal muscle weakness. In the legs, patients will tend to say things like, I can't get up from the chair. I have to push up using my arms. I have difficulty getting out of the bathtub. I have difficulty getting up off the toilet. I have trouble going up a flight of stairs. If I'm sitting on the floor, I have to crawl over to the wall to pull myself up. In the arms, they tend to say things like, I have problems getting something from a top shelf. I have problems changing a light bulb. I have difficulty doing my hair. I have to prop my arms up on the vanity. I have difficulty holding my arms up when I'm doing my makeup. They don't tend to say, I have difficulty turning pages. I have difficulty texting. I have difficulty opening a jar. I have difficulty using a spray bottle. They don't tend to say things like that. And there are authorities who say that in Lambert-Eaton, that it 100% of the time starts in the proximal musculature as opposed to the bulbar musculature. Now, I'm 53 years old, and I've learned that there's very few nevers, and there's very few alwayses in life, much less in medicine. Now, having seen 5 at the most cases of Lambert-Eaton myasthenia, I have not seen a case that started with ptosis or with diplopia. I certainly can't say always. I can't say never, but I will say that it's supposed to start in the proximal musculature. It may eventually result in ptosis, diplopia, dysarthria, dysphagia, but those aren't the hallmarks. The common symptoms are going to be that proximal muscle weakness, so it may mimic myopathy. When you see a patient who looks like they have a myopathy, it's always worth considering. That's particularly important once you get down to the electrodiagnostic testing, the EMG with nerve conduction studies, which I'll get to in just a moment. So the other thing that is really helpful from a clinical standpoint in distinguishing Lambert-Eaton myasthenic syndrome versus other neuromuscular junction disorders is that autonomic difficulty. Patients very commonly will complain of dry mouth, constipation, blurry vision. Males will complain of erectile dysfunction, but they very rarely complain about it. You're going to have to ask them. That's where the review of systems is extremely helpful. So you make sure that is on that review of systems form that you hand out to pretty much every patient. You look over it. Again, patients are very unlikely to tell the neurologist, I have dry mouth, I have constipation. You're going to have to look for it. But from a clinical standpoint, the other thing that we really think about is the presence of facilitation. So in Lambert-Eaton myasthenic syndrome, they have weakness that tends to improve briefly with exercise. When you examine your patient, you may see some proximal muscle weakness that improves with use. Most patients who have Lambert-Eaton myasthenic syndrome also have either diminished or absent reflexes. And as you tap the patellar reflex over and over and over again, that patellar reflex very commonly will come back, facilitation. From an electrical standpoint, on repetitive nerve stimulation testing, they may have a decremental response that looks very similar to that of myasthenia gravis. The textbooks very nicely show what happens when you do rapid repetitive nerve stimulation, 50 times per second, and it shows that very nice incremental response that may increase 100, 200%. I've never done that test to a patient because it is notoriously painful. So I think from my standpoint, the best test in the EMG lab is the Lambert-Eaton myasthenic screen. So anytime that I see a patient who looks like they have diminished CMAP amplitudes, if they have that diminished peroneal nerve response, that diminished tibial nerve amplitude, I'll make sure I have the patient exercise for a minute and recheck the amplitude. And if there's a marked increase, I really need to think about Lambert-Eaton myasthenic syndrome, even if they don't have obvious autonomic problems, even if there's not any obvious history of weight loss, anything to suggest underlying neoplasia. That's the kind of patient that I really have to consider sending for the antibody testing. And the antibody testing, again, is that for the presynaptic voltage-gated calcium channels. So this is a presynaptic disorder resulting in diminished release of acetylcholine. Very classically, we think of this as a paraneoplastic disorder. About 2/3 of patients will have underlying neoplasm, most commonly small cell lung cancer. That's the only neoplasm that I have personally seen with Lambert-Eaton myasthenic syndrome, but there's plenty others that have been reported. In cases where there is underlying tumor, the prognosis tends to be worse, the progression tends to be more rapid, and about 75% of those patients are male. But about 1/3 of the time, you can look, but there is no neoplasm. That has a better prognostic course. The life expectancy is normal, and there's not that male predominance. If there's no underlying neoplasm, it's about half males and half females. But then in addition to the treatment, you also have to consider the presence of other autoimmune diseases. I think everyone here is taking care of patients with myasthenia, polymyositis, multiple sclerosis, something that's autoimmune, and then they happen to develop thyroid disease, or they develop B12 deficiency from pernicious anemia. So you have your patient who has fatigue, and they have Lambert-Eaton myasthenic syndrome, or myasthenia gravis, and they don't get better. You have to think about, is there something else? Do they have anemia? Do they have low B12? Do they have hypothyroidism? Maybe they get better with treatment, and then they get worse. Do they have another condition? So you always have to think about the presence of other autoimmune diseases. The treatments that we use, pyridostigmine is commonly used, acetylcholinesterase inhibitors to increase the amount of acetylcholine that's in the synaptic cleft. It's an immune-mediated condition, so prednisone is commonly used, plasma exchange, IVIG, and then what's new? Well, we have some developments in 3,4-diaminopyridine. This is not a new treatment. This is something that's been out for a while, but there have been some very significant developments just in the last year or two. So some of you may recognize this as the screenshot from Neurology Today, which we get regularly across our desks. So 3,4-diaminopyridine traditionally has been provided at no charge by Jacobus Pharmaceuticals. Lambert-Eaton myasthenic syndrome is a very rare disease. 3,4-diaminopyridine traditionally has been a fairly cheap drug to make. It was provided at no charge. But for several years, the salt formulation has been available in Europe, made by Catalyst and sold under the name of Firdapse. So several years ago, Firdapse applied to markets 3,4-diaminopyridine under the name of Firdapse under the Orphan Drug Act, which was approved. And so that gave Catalyst 7 years of exclusive rights towards marketing, towards producing Firdapse for Lambert-Eaton myasthenic syndrome here in the United States. Well, Jacobus immediately turned around and marketed their own form and received FDA approval for children ages 6 to 17. There was a lawsuit that was quickly filed saying this violates the Orphan Drug Act because we have exclusive rights. And a lot of the legal basis for this was that patients were able to obtain the Jacobus version that was approved for ages 6 to 17 on an off-label basis. So adult neurologists were prescribing this medication off-label because it was a pediatric indication for the adult Lambert-Eaton myasthenic syndrome patients, except for the fact that the critical study was not on children. The critical study was only for adults. So it went back and forth. Originally, district court ruled in favor of Jacobus. It went to federal court where just a little less than half a year ago, there was summary judgment that was in favor of Catalyst. So right now, if you want to get your patient, whether they have congenital myasthenia, whether they have Lambert-Eaton myasthenic syndrome, if you're looking to prescribe 3,4-diaminopyridine, right now, the only way you're going to get it is Firdapse through Catalyst. And for those of you who are interested in reading more, it's easily found. Neurology Today. I had read up on this again last night, so I know that this is still easily available online. The concern is it was provided free before. Now, traditionally, Firdapse, if it's written for, is about $171 per pill. And that's for the 60-milligram tablet. Now, Catalyst has set up charitable organizations, patient assistance programs. So my understanding is that through the assistance programs, patients are able to get the medication for $2 a month. But for those of you who are interested in all of the legal ramifications and how this went down, you can easily find this article. But as it stands right now, as of September 2021, the federal court has ruled that Catalyst has exclusive rights under the Orphan Drug Act. So from there, let's go to another unusual condition, congenital myasthenic syndromes. So it's a condition that might be a little difficult at first glance to distinguish from autoimmune myasthenia gravis. There usually is not a family history. I mean, if there's a family history, it's easy for us to think and to figure out this must be something that's congenital. But there usually is not a family history for congenital myasthenia, with slow channel syndrome being the big exception. It can look very, very similar. Patients can have the ocular weakness just like myasthenia, autoimmune myasthenia. They can have the bulbar weakness just like autoimmune myasthenia. They can have the generalized weakness. They can have the respiratory weakness. There are some important differences. First of all, these conditions tend to pop up in the pediatric population. They tend to pop up during childhood, during the teenage years, which is obviously much earlier than the typical generalized myasthenia gravis patient that we see. Patients may have arthrogryposis. If you see a patient who looks like they have myasthenia, who has arthrogryposis, that's a big red flag. that should make you consider the possibility of congenital myasthenia gravis. Patients may have involvement of wrist and finger extensors. We're used to thinking in muscular dystrophy about the exceptions. So that patient who comes in who looks like they have muscular dystrophy, who have calf wasting, who they have severe weakness of the posterior compartment below the knee. You think of Myoshi myopathy, you think of ANO5 mutations. Those are the things, the exceptions that really stand out. If you see a patient who's got marked weakness of the wrist extensors and the finger extensors, and they look like they have myasthenia, that's a big red flag for congenital myasthenia. Specifically speaking for slow channel syndrome and for end-plate acetylcholinesterase deficiency. Patients may have pupillary abnormalities in congenital myasthenia. Myasthenia gravis, the autoimmune form, is not supposed to involve the pupils. If you see a patient who has myasthenia, who has pupillary involvement, think of congenital myasthenia gravis. Diminished tendon reflexes, that may not be quite as helpful because lots of patients have diminished tendon reflexes. That's not very specific for anything, but just might be a clue. And then episodic apnea, that's also a big clue. That doesn't really happen in patients with immune-mediated myasthenia gravis. So if you see a patient who has any of these features, those are tip-offs that it's not such a simple case. Maybe you should think about an alternative diagnosis to the garden variety autoimmune myasthenia gravis. We mentioned that the onset is usually during infancy or childhood. Repetitive nerve stimulation usually shows that decremental response of at least 10%, usually, although certainly that's not entirely specific or sensitive. The edrophonian test is often positive based on how that's working at a molecular level with inhibition of acetylcholinesterase and increased acetylcholine in the synaptic cleft. That's not much of a surprise. Obviously, by definition, the acetylcholine receptor antibody testing is going to be negative. And basically, universally, this is a genetic diagnosis, but that's not the kind of test that you can just turn around and send to Quest or LabCorp. You're going to need to really work with a specialty lab to try to get a genetic diagnosis. So, okay, that was easy. Let's talk about myasthenia gravis. We've talked about a lot of the rest of neuromuscular disease and the new developments. So there's really been an explosion in the management and in the treatment of myasthenia gravis. There hasn't been so much of explosion as far as the diagnosis. So there's some new antibody testing, which we'll talk about in just a moment. But when I was in residency, this is how we really thought about autoimmune myasthenia gravis. And we thought that we understood the neuromuscular junction. We heard yesterday, settled science is very rarely settled. Our knowledge is always changing. So, and what I talk about with my patients, I'll tell you exactly what I tell my patients, that myasthenia gravis is an autoimmune disorder due to antibodies against the postsynaptic acetylcholine receptor. We talk about binding antibodies, blocking antibodies, modulating antibodies. What I tell my patients is that when we want to move a muscle, we send the message down the nerve. Once it reaches the end of the nerve, we have bags of chemical here called acetylcholine. Acetylcholine is dumped into the synaptic cleft between the nerve and the muscle. And just like a drop of food coloring that you drop into a glass of water and it spreads out the same way, the acetylcholine spreads out over here and attaches to the acetylcholine receptor. We have these very nice folds, and the acetylcholine receptor tends to be concentrated at the tips of these folds, and it causes the message to get sent through to the muscle and causes the muscle to work. That was a very, very good explanation of what happens at the neuromuscular junction during the 1990s. And that's still how I'm going to explain things to my patients. And we'll talk about the treatments. I talk about oral medications. We have pyridostigmine. So once again, that's an acetylcholinesterase inhibitor. So you're not breaking down acetylcholine. You're going to have increased acetylcholine in that space between the nerve and the muscle. And then we have lots of different medicines to suppress the immune system. I think most of us are very comfortable and very used to reaching for prednisone. And we use steroid-sparing agents like azathioprine and mycophenolate. And then based on where we did our training, there are other medicines that we may or may not feel comfortable reaching for at different centers. People may be trained to prescribe methotrexate, or cyclosporin A or tacrolimus. In other patients, we need to consider other treatments. So on the right side, we have more of our invasive or more aggressive treatments. So first of all, there's spymectomy. Obviously, every patient who has myasthenia gravis needs to have a CAT scan of the chest because a third of patients who have myasthenia gravis are going to have a thymoma. Another third of patients will have thymic hyperplasia, which is not really something that you can see in a CAT scan, but when you look under the microscope, you'll see it. And a third of patients have a pathologically normal sinus. So traditionally, what we think of is if they have a thymoma, if they have their CAT scan of the chest, they've got an anterior mediastinal mass that needs to come out. Obviously, you look at risk-benefit ratio, the patient who has AIDS and heart failure and atrial fibrillation and advanced COPD and Parkinson's disease who now has a thymoma, maybe you're going to wind up leaving them alone. Maybe you're going to do more harm than good. But normally we say that the cutoff is around the age of 60. If you have a patient who is under 60 who has generalized myasthenia gravis, that traditionally we say probably they ought to have their thymus cut out. Over the age of 60, if they have generalized myasthenia gravis, probably you're going to leave them alone. Now, that's not a hard and fast number. Again, that patient who I mentioned who is 59 years old, who has advanced CHF and advanced COPD and metastatic cancer that's everywhere, who's 59, who has generalized myasthenia gravis, I'm probably not going to send them to have their sternotomy and have their thymus taken out. On the other hand, the 61-year-old patient who's running marathons and doing the MS-50 in one day instead of two, I'm probably more likely to consider sending them for a thymectomy. We commonly use Rituximab, plasma exchange, and IVIG. Those are medicines that aren't necessarily first line, but are commonly used either for patients who have more aggressive disease or patients who there are reasons to where the medicines in that first column are not as attractive. There's a problem as far as drug interactions. If there are other medical conditions, your patient who has brittle diabetes, do you want to start them on prednisone? Maybe not. So these are some of the medicines and some of the treatments that we commonly use in the treatment of myasthenia gravis, but there's a couple of new players to the game that are important to mention, and these are really the exciting developments. So traditionally, we go with these other treatments that you see on the left and also at the top on the right, but what they have in common is that they tend to be general immunosuppression, and they come with a lot of potential side effects. So now we are looking at treatments that are really much more finely honed based on the pathophysiology of the disease. We have a couple of these treatments, and there's a couple that are probably coming down the pike. So let's talk about those. So we talked about our expanding knowledge. We talked about that what I showed you early was a perfectly good diagram of the neuromuscular junction for the 1990s, and that's still what I pull out and I explain when I'm talking to my patients. So actually, I draw that out on butcher paper and talk about the receptor and talk about acetylcholine. When I'm done, I tear that page off and I give it to my patients so that they can take it home and think about it. This is a more 21st century diagram of the neuromuscular junction and of the acetylcholine receptor. So it's very, very complicated based on comparison to the first diagram that you saw. And a lot of this explains why patients may be seronegative. So it used to be that we would hear about 80% of patients who have autoimmune myasthenia gravis have antibodies, binding, blocking, modulating. And then in the early 90s, we started to be able to test for MuSK antibodies, for muscle-specific kinase. And around 5, maybe up to 10% of patients who have myasthenia gravis are felt to have MuSK antibodies. And that would explain why they were not testable before. We would say, we know they have myasthenia gravis, but they're antibody negative. We can't figure out why. Well, there was an antibody that we hadn't discovered yet, and so now we know about MuSK-positive myasthenia gravis. And then we discovered LRP4 antibodies, which you can now test for commercially as well. So now we say around 85, 90% of patients with myasthenia gravis are antibody positive, but there's still that 10%, maybe 15% of patients who you know that they have autoimmune myasthenia gravis, but you just can't find the antibodies. And some of that may be because it's an antibody that has not been discovered, or an antibody that has been discovered but is not commercially available. It's just not enough yet. So there's been antibodies that have been reported against agrin and contactin, ryanine receptor, titin, collagen 13. Myasthenia gravis is a more complicated disease, and it's not one disease. So just like we learned with muscular dystrophy, well, there's dystrophinopathy, and there's myotonic dystrophy, and there's FSH, and there's all these different types. It may be that myasthenia gravis is several different conditions, and years from now, we may be talking about myasthenia gravis type 1, type 2, type 3, but that's in the future. Right now, they're all myasthenia gravis. But our ability to detect it is improving. That number of patients who have antibodies is gradually going up. But the pathophysiology is still the same. So what we talk about is that you have our presynaptic phase here, and it releases acetylcholine into the space between the nerve and the muscle, and it diffuses across, and at the top of the synaptic fold, we have our acetylcholine receptor. And the antibodies cause problems by a variety of different ways. So we talk about binding antibodies, we talking about modulating antibodies, we talk about blocking antibodies. They each are their own pathophysiologic mechanism. So let's talk about the functional blockade first. So the way I explain that to my patients is basically an antibody is like an enzyme. It's like a lock and key. Think about going up to your front door and you want to put your key in the hole, but someone's put some gum, some chewing gum over your keyhole and you can't get it in. You can't put the key in the lock. That's blocking antibodies. So the blocking antibodies is the acetylcholine receptor antibody binding to a non-active site that stops acetylcholine from actually getting to the binding site. We have modulating antibodies where you have an antibody that binds not to just one receptor, but to two receptors. And by doing so, it causes the postsynaptic face to invaginate, to absorb these acetylcholine receptors and to degrade them. And then when acetylcholine comes and diffuses across, there's no receptor. There's nothing for acetylcholine to touch to trigger that muscle activation. But I think that from a pathophysiologic standpoint, the most important mechanism is the binding antibodies. And again, in the 90s, it was sufficient to say that binding antibodies came and they bound and it caused damage to the postsynaptic membrane. Well, let's talk about treatments, but we now know it's a little more complicated than that, that it doesn't appear to be the antibodies that are actually causing the problem. The binding antibodies are a marker for destruction. And the mechanism that mediates that is complement. So complement, and we'll get to that, we'll talk about the complement cascade, but complement is an important innate function of the immune system. And when complement is alerted, complement causes problems to whatever it is supposed to attack. And complement is what actually appears to mediate the damage to the postsynaptic face. And there's some very nice EMs. You may have seen these before. These show up in conference after conference after conference, to where on the left you see a normal neuromuscular junction. You see these very nice synaptic folds. In here on the right, you see a patient who has chronic myasthenia gravis, and these dark deposits are actually complement. You can see the complement is deposited on the postsynaptic face, and you've lost all of these nice ridges, you've lost all of those nice folds because of chronic damage to the postsynaptic face. So complement, as I said, it's an innate function of the immune system. It's fairly complicated. I know everyone here remembers very fondly studying the complement chain back in medical school. So I don't want to spend too much time on this slide, but want to talk about it a little bit briefly. So the complement cascade is very important, not only in autoimmune diseases, but also it's important in apoptosis, that the body is able to mark cells that need to be destroyed. It's important for fighting bacteria, in particular encapsulated bacteria. So we have what's called the proximal component. This is basically up the chain. And we have the terminal component, which is down the chain. And there's different functions, both proximally and distally, not only punching a hole in the membrane, but also with pro-inflammatory molecules. So we have our uphill chain, but then the terminal portion where everything comes together is at the C5 level. So C5 is cleaved into C5a and into C5b. And when that cleavage occurs, there's this final, what's called the terminal complement cascade, or the membrane attack complex, or C5 through 9, that basically punches a hole inside whatever it's targeting, whether it's the cell that's supposed to be destroyed because of apoptosis, or whether it's your encapsulated organism. That's particularly important because encapsulated organisms and fighting them off are really, really dependent on the complement cascade. So if a patient has their complement system inhibited, they are going to be potentially prone to meningococcus. So any patient who's on medication for this has to get the meningococcal vaccination. Interestingly, other organisms don't seem to be so prone to be involved if complement is inhibited. You would think about Streptococcus, but Streptococcus actually has a very thin cell membrane. The body doesn't seem to have trouble lysing and getting rid of Streptococcus under normal circumstances, but in our patient who has a complement system that is not normal, we are not able to fight off that very thick cell membrane. That's why we may be prone to meningococcus under those circumstances. But it's that terminal complement cascade, the MAC, the C5 through 9, that punches the hole in whatever. And in immune-mediated disease, whether it's neuromyelitis optica, whether it is autoimmune myasthenia gravis, that's what actually causes damage. But again, it's not the antibodies. The way I explain that to patients is that I love watching nature videos. I'll get on YouTube and I'll watch nature videos, and sometimes a video will come up lions or tigers or hippos. You think about bees. And let's say you have a beehive. And how do the bees know to swarm? Well, you have your scout bees that fly around and they find something that they want to attack and they spray their pheromones. They mark that target as something to be a target of the hive. And then the scout bees fly back to the hive and they do their little dance and make their noises, and the swarm comes and they find the pheromones and the bees attack. It's not the pheromones that cause the problem. The pheromones are a marker. The swarm is what causes the problem, but the pheromones are the marker. So binding antibodies don't directly cause the damage. It's a marker. The antibodies are like the pheromones. That swarm is the complement. That's how I explain this mechanism of action to my patients. And this is a class of medications that's actually been around for a while. So I think the best known complement inhibitor is Eculizumab. That actually inhibits C5 being cleaved into C5a through C5b. It's been on the market for about 15 years for other indications. It's been used for atypical hemolytic uremic syndrome. It's been used for paroxysmal nocturnal hemoglobinuria. But then around 2 years ago, 3 years ago, it got the approval for antibody-positive generalized myasthenia gravis, the first medicine ever approved by the FDA for myasthenia gravis. And I've had people say to me, what about pyridostigmine? We've been using Mestinon for 50, 60, 70, 80 years. That's been around forever. Of course it's FDA approved. You'd think it would be. Pyridostigmine is older than the FDA. Pyridostigmine was here before the FDA, so it was grandfathered in. Pyridostigmine never received its indication for myasthenia. So Eculizumab actually is the first medicine with an FDA approval for myasthenia gravis. So it's newer on the block as far as treatment, but it's not really a new medicine. It's been around for 15 years for other indications, and it's also not FDA approved for neuromyelitis optica. There are other complement inhibitors as well. I mean, there's Ravulizumab, not approved for neurologic indications. That's Ultomiris, thought to be a longer acting form, very similar to Eculizumab. My understanding is that there may be some trials that are ongoing, but have not reached completion yet. And then there's C1 inhibitors used in hereditary angioedema, and there's C3 inhibitors, which are FDA approved for paroxysmal nocturnal hemoglobinuria. So based on where you are looking in the complement chain, there's different ways that you can inhibit for different diseases. So this is something that we're going to be continuing to see in the future, not only for myasthenia gravis, but potentially for other diseases. So we mentioned an estimated 85, 90% in the series that I have read most recently of generalized myasthenia cases have detectable levels of acetylcholine receptor antibodies, most specifically binding, blocking, and modulating. And it makes sense that complement inhibitors would work because the bulk of those antibodies for myasthenia are IgG1 and IgG3, which are complement dependent. It doesn't really do anything for IgG4 and very, very little for IgG2. People have asked me, what about MuSK myasthenia gravis? MuSK is IgG4. MuSK antibody positive myasthenia gravis shouldn't work. I have not seen any studies, but from a pathophysiologic standpoint, MuSK is IgG4. MuSK is not complement mediated, so it shouldn't work. So complement inhibition really is for binding, blocking, and modulating antibodies. And when you look at the data, there was a study that was done where they actually looked at patients who had refractory myasthenia gravis, antibody positive. So this was a cohort of patients who had refractory disease for at least a year. These patients had to be on 2 different immunosuppressive medications and still be uncontrolled, or to be on 1 immunosuppressant medication in addition to chronic IVIG or in addition to plasma exchange. And this was the critical slide in the study, and the endpoint was the Mgadl score. So the Mgadl score is from 0 to 24. They look at 8 different domains, of which 0 is nothing and 4 is the most severe. So for example, if you're talking about respiratory status, if a patient has no respiratory problems whatsoever, they would get a 0. If they're ventilator dependent, they would get a 4. When you're talking about dysphagia, if you have no symptoms at all, you get a score of 0. If you have a PEG tube or a nasogastric tube because of your severe dysphagia, you're going to have a 4. So you look at these 8 different domains, a 3. You look from 0 to 3, and based on whatever your score is, you can be up to 24. So what this slide looks at is the change and the Mgadl score. So at the beginning of the study, you can see at 0 weeks, the patients are at the same place. That makes sense because they haven't received medication yet. But when you give patients complement inhibitors, when you give them eculizumab, you can see that there's a pretty quick separation between the placebo group and between the drug group, placebo and drug. And that maintained all the way through 26 weeks. And afterwards, patients were allowed to cross over. They could go into the open label extension. So those patients who had been on placebo got drug and immediately caught up with the placebo group, which was maintained throughout the entire duration of the study. Admittedly, this is completely subjective. This is based on patients' reports. This is not based on examination. So one of the other endpoints that they used was the QMG scale. This is exclusively objective. This is based on the physician assessment, not based on patient reports. And you just see the same kind of curve where this is the change. How much of a change was there in the MGAD score, and MGADL or the QMG score, 2 points, 4 points, 6 points, 8 points. This is out of 39, the QMG. And you can see those patients who were on placebo had very little improvement, whereas those patients who received eculizumab, those who were in the trial arm, had marked improvements, and that after there was a crossover, there was improvement that went through the entire duration of the study. So, I mean, it looks like a good drug, and this was something that was approved. Well, the study was for refractory patients, patients who were very stubborn as far as their myasthenia gravis, very refractory to treatment. The indication, however, is for generalized myasthenia gravis. They don't need to be refractory. So I've had some pretty good experience using this medication. It's very efficacious. It's very well tolerated. We have around 15 to 20 years of safety data in other conditions. you have to make sure that they're vaccinated. That's the most important thing. But there are some increased reports of musculoskeletal pain. There are some increased reports in some series of diarrhea. But it's really, really well tolerated. It's a 35-minute infusion. The improvement, as you saw on those scores, are pretty rapid. The disadvantages, first of all, it's an intravenous drug. It doesn't require a portacath. It doesn't require a PICC line. It doesn't require a central line, but it is an intravenous medication. There is the slight risk of immunosuppression, especially meningococcus. When you looked at the open label extension, there were patients who got UTIs, there were patients who got respiratory viruses. Again, this was an open label extension, so there was no comparison. They cannot say it was an increased risk. But clearly, it's something to think about. You have to think about cost. It's more expensive than prednisone. It's better tolerated, and I think patients like it better than other traditional immunosuppression. But then the big question that I think that needs to be considered is how long are you going to continue patients on this treatment? Are you going to continue it for the rest of their lives? I don't know. Are you going to continue it for a year? I don't know. Are you going to continue it for 3 years? We don't know exactly how are you going to continue it. I think it's a good choice for patients who have refractory disease. I think it's a good choice for medically complicated patients who are older, they're more frail, they're more fragile. You don't want to put them on these immunosuppressant medicines and steroids. And if I have an 80-year-old patient, do I think I'm going to be keeping them on Soliris, on Eculizumab for another 50 years? They're 80 years old. Probably not. But how do we think about this fitting into the paradigm long term? That's something that has to be considered and worked out. And then the newest kid on the block is the Neonatal Fc Receptor antagonists. I think that Neonatal Fc Receptor is a slightly unfortunate term, but one that we're stuck with, similar to patients who come in and ask me about the Chiari malformation, and I have to talk about their cerebellar tonsils, and I have to make sure that they understand when I'm talking about their tonsils, I'm not talking about what's in their throat. I'm talking about what's in their cerebellum, and that's an unfortunate coincidence, but one that we're stuck with. So I think that there's going to be a lot of confusion, not only with patients, but even some doctors about the neonatal Fc receptor. What are you talking about? Neonatal treatments? And I'm an adult. So it was first discovered, it was first worked out in neonates. Actually, the seminal work was done by Sally Ward just up the road in Dallas, who worked out a lot of this. So the reason it's called the neonatal Fc receptor is because it's very important during pregnancy. The neonatal Fc receptor is how antibodies are transferred from mom to the baby. We all know, we all think about that mom gets the antibodies over, and they last for about 6 months, and so the baby has some degree of immunity when the baby comes out of mom. The way that this happens is across the syncytial trophoblast inside the placenta. So the Fc portion of IgG binds to the Fc, the neonatal Fc receptor, with very high affinity. So what you see over here on the maternal side is that you have neonatal Fc receptor here that's inside this endosome that forms. At physiologic pH, there's not a lot of affinity, but inside the endosome, there is much higher affinity at an acidic pH. And so IgG binds to the endosome, is transferred across the placenta, and then at the fetal circulation, it's a physiologic pH, and IgG is released. And so these antibodies are transferred from mom to the baby. So this is where the neonatal Fc receptor was discovered and why it's called the neonatal Fc receptor, but it's also used in adults, but for a different reason, for a different mechanism. But we're stuck. We can't say recycling receptor. We're stuck with the term neonatal Fc receptor, even though none of us are neonates. So in adults, the neonatal Fc receptor is very important for recycling of IgG as well as albumin. And it occurs mostly in the vascular endothelium. Neonatal Fc receptor is very highly expressed in that endothelium, also in antigen-presenting cells. So what happens is that once again, we have our physiologic pH. And at physiologic pH, there's not a lot of affinity for IgG with the neonatal Fc receptor, but once it is absorbed, we have a more acidic milieu, And under those circumstances, IgG binds to the neonatal Fc receptor, and then anything that doesn't bind is transferred to the lysosome and degraded. It's trash. It goes away. But we have an impetus for wanting to recycle our IgG. It's makes a lot more sense to recycle our own IgG than to have to synthesize it anew. So for that IgG that binds to the Fc receptor, it doesn't get degraded. It doesn't go to the lysosome. Instead, it comes back out, it binds again to the endothelium, and IgG is released because the affinity is not so high here in the circulation. So this is very important. This is our mechanism. All of us have this for recycling and prolonging the half-life of IgG. So there's been a lot of work, and again, the seminal work was done up in Dallas to say what happens when we stop the neonatal FcR, what happens when we inhibit that. And there are several different medicines that are being looked at. Efgartigimod is the one that is on the market, was approved about a month and a half ago for myasthenia gravis. We'll briefly look at some of the data. So when you inhibit IgG, when you inhibit the neonatal Fc receptor, what happens is that you have our vascular endothelial cell, and you have our endosome here, and what's supposed to happen is that the neonatal Fc receptor binds to our IgG. However, if you have an IgG analog, if you have an antibody that looks like IgG, it will preferentially bind, and IgG won't bind. It's going to be left floating inside the endosome because the antibody, the neonatal Fc receptor inhibitor, has a higher affinity. So when that occurs, the antibody is what actually binds. IgG does not bind to the neonatal Fc receptor. So IgG is transferred to the lysosome, and IgG is degraded. And the contents of the endosome, and specifically the neonatal Fc receptor inhibitor, comes back to the endothelium as released, and IgG is degraded. So the mechanism of action for the neonatal Fc receptor inhibitors is increased IgG degradation. You're getting rid of IgG. So the way that I am explaining this to my patients, it's like a miniature plasma exchange. I mean, plasma exchange, I think, makes a lot of sense to patients. It's kind of like a mini dialysis that you suck the blood out and you filter it through the machine and you get rid of the IgG, you get rid of the antibodies, you get rid of the proteins, and you give the patients back their own blood. This, in a similar way, it's getting rid of IgG. You're causing IgG to not be recycled, and you're lowering the IgG levels. And that's reflected in the studies that have been done. What happens to IgG levels after you give these neonatal FcR receptors? And there are different subtypes looked at: IgG 1, 2, 3, and 4. What they all have in common, you can see after you inhibit the neonatal Fc receptor, you can see that there's this marked decrease across the board of IgG levels that with time comes back to normal as the body starts to synthesize IgG again. Because you're not recycling, the body has to synthesize it the same way that we tell our patients, you're going to suck the antibodies out in plasma exchange. Your body will make them back, but this will get you a boost. This is going to get you out of crisis. This is going to make you feel better. So the neonatal Fc receptor inhibitors lower IgG levels that then come back, but that's reflected when you look at the patient's response after they receive the neonatal FcR inhibitors, once they get efgartigimod. So you see this looks very much like the slides that we just saw, looking at IgG levels in those patients who received the neonatal FcR receptors. On the left, you see the response, the Mgadl score, just like we saw before. This is completely subjective. When they get their neonatal Fc receptor inhibitors, when they get their efgartigimod, the change in their Mgadl score is obvious, looking at placebo compared with patients who received medication. As well as objectively, on the right, we can see here's our QMG. And patients, you can see on the y-axis, we have the change in the QMG. And with time, you can see that there's a change, that patients get better compared with placebo, but then with time, your body makes the IgG back. and it grows back, very similar to plasma exchange. So this, like I said, this was approved about a month and a half ago. It looks fairly good. I have not yet prescribed it, but the efficacy makes sense. It's like plasma exchange. The mechanism makes sense. It looks pretty well tolerated, and similar to plasma exchange, you would expect to have a relatively rapid onset of improvement. What are the disadvantages? Well, similar to what we saw before, this is an intravenous medication. No PICC line is required, no central line. That's a big advantage over plasma exchange, where a lot of the patients who need plasma exchange are going to need a central line. Not all of them, depends on the institution. Interestingly, there's a reduction in white blood cell counts. We're not sure why that is, but it's very well established that there's a slight dip in the white blood cell count, up to about 12% of patients who received efgartigimod, as opposed to 5% in the placebo group. Again, we're not sure why that is. They did not see an increased risk of infection during the study. Again, that's something that will need to be watched with time because we don't fully understand why that occurs. Once again, how long are you going to treat patients with this? It's not like we commonly use plasma exchange forever. It's more as an as-needed treatment if patients are in trouble. In the study, what they did was that they allowed patients to get a first course of efgartigimod, and if needed, they could get a second course, and if needed, at the discretion of the treating physician, a third course. But that was it during the study. How is that going to translate to clinical usage? That's something that needs to still be worked out. And then it's going to be more expensive than a lot of the medicines that we traditionally use. So in summary, settled science, like we heard yesterday, is very rarely settled. Our understanding of the structure, but also the function of the neuromuscular junction, is an evolving science, and our understanding of the potential treatments is an evolving science. Traditionally, we tend to use medication that overall suppresses the entire immune system and comes with a lot of potential pushback and problems with involvement of other areas. Now that we have treatments that look more at the underlying pathophysiology, it looks like those treatments have some big advantages. But how are we going to integrate that into our overall approach? That's something that we still have to work out. So from there, let me open things up and ask what questions everybody else has. Thank you.
Dr. Lovitt, you complied with the request to talk about other neuromuscular junction disorders for about 12 minutes. And I must commend you for how you used the remaining 40 minutes of your presentation. It was excellent. And I have to agree with our patients that you were able to present these very complex concepts in a way that even I could understand. So thank you, sir. We have a question that I think you have addressed, was the question of how long to use some of this. So for how long do you treat with the eculizumab? And you, I think, answered that. I don't know if you want to expand a little bit more on that.
Yeah, I'll talk a little bit more about that. I have more experience with eculizumab than I do with efgartigimod because, as I said, efgartigimod was only approved about a month and a half ago. I've used eculizumab on quite a few patients, and like I said, I will jump to eculizumab very quickly in one of a couple of situations. For a refractory patient who comes in to see me, a patient who's had myasthenia gravis for a long time. So I saw a patient, for example, I think I was the third neurologist that she had seen, and I was not the first neuromuscular specialist that she had seen. She originally presented, before I met her, in myasthenic crisis. She had a hysterectomy, but could not be weaned from the ventilator, and that was the impetus for the diagnosis of myasthenia gravis. And she was maintained on prednisone and a steroid-sparing agent, but developed diabetes and wound up being started on Ivig. And for years before I ever saw her, she was on Ivig about every 3 weeks, which was enough to keep her out of the hospital. But she couldn't work. She stayed close to home. She did not have a great quality of life, but was out of the hospital. So I assumed her care. And not after I assumed her care was when the word came down that there was a new medicine that was going to be, looked like it was going to be approved for the use in refractory myasthenia gravis, and I thought, this is fantastic. This is exactly what this lady needs. This is an obvious case of refractory myasthenia gravis. And I can say she's working again. She's back in the workforce, holding down a job and having a normal life, and she's very happy. How long am I going to keep this lady on medicine? Well, she has very refractory disease, and people have thrown the book at her. And I think it's been well established that it's not going to work on her. So in her case, I am more likely to continue eculizumab for a longer period of time. At some point, I'm going to have the discussion with her about, you're on medication every 2 weeks. Do we want to consider pushing out to every 3 weeks? And there's no data to support that. That's the kind of thing that has to be worked out as far as coming out with a generalized approach. On the other hand, let's say that we have a patient who comes in, they're in myasthenic crisis, they're 30 years old, and they're treated with eculizumab in the hospital, and they get off of treatment. They're 30 years old, they're healthy. I'm probably not going to want to treat them with eculizumab for 50 or 60 years if I don't have to. I am more likely to use eculizumab as a bridge under those circumstances. And once we get their symptoms under control, maybe we can start them on prednisone. And with time, the prednisone starts to kick in. We can gradually go up on the dose and then come down on the dose of eculizumab. And we talked about the beehive in the same way. The bees are still there. If you stop blocking the pheromones, sooner or later, the bees are going to swarm. This is not a treatment that actually gets rid of the antibodies the way that prednisone. It stops the immune system from responding to the antibodies. So under those circumstances with a younger patient, I think it's important to think about, do we want to, at some point, think about tapering you from eculizumab, but if you haven't used another treatment, the beehive is still there. And sooner or later, those bees are going to swarm. So if you're going to try to get the patient off eculizumab at some point, you need to think about another treatment while the eculizumab is working, while you have that time of a decreased myasthenic burden. But in the end, we don't know.
Your answer was so good, and as it is often said, no good deed goes unpunished. Now we have another 6 follow-up questions. So let's start from the beginning. How to deal with seronegative myasthenia and that don't do well on rituximab?
So seronegative myasthenia gravis is tricky. I don't like the diagnosis of seronegative myasthenia because the symptoms of myasthenia can be very vague. The fatigue and the weakness. I need something to hang my hat on, and the antibody status may be negative. The repetitive nerve stimulation may be negative. Under those circumstances, the single fiber EMG can be immensely helpful as something to hang your hat on, the same way that an edrophonium test and an ICE test can be helpful. The single fiber EMG is tremendously sensitive, but it's not very specific. But under those circumstances, it's something to hang your hat on. But once I've decided that they truly have seronegative myasthenia gravis, in general, I'm going to treat them the same way that I will a seropositive myasthenic patient. So eculizumab would be an off-label indication. Interestingly, the efgartigimod study included seronegative patients, although that would also be an off-label indication. The FDA did not approve it for seronegative patients, but it could be used. But for a patient who had seronegative myasthenia gravis, in whom I was convinced about the diagnosis, I would do treatment the same way. I would be apt to potentially start steroids at a low dose. Again, you cannot start it too quickly. If you start steroids too quickly in a patient with myasthenia gravis, they're going to get worse before they get better. So I will start it usually at 5 milligrams every other day and then gradually increase the dose with time and see how they do. And depending on how they do, maybe add on a steroid-sparing agent. Maybe I'll think about Rituxan. Maybe I think about IVIG. But once I've reached that point, I don't really treat them any differently than a seropositive myasthenia gravis patients.
2 down, 4 to go. The next one is management of isolated bulbar myasthenia, who is antibody negative.
Management of isolated bulbar myasthenia, and I assume that you mean I assume you don't mean ocular myasthenia gravis. Now, there are people who don't think that there is such a thing as ocular myasthenia gravis. I think that's a little bit of an overstatement. But just like patients with Lambert-Eaton myasthenic syndrome always start in the arms and leg, always. I've seen people who say, well, there is no such thing as ocular myasthenia. Yeah, they look ocular. Have them come back in a year, they'll be generalized. They come back in a year. They're still ocular. Don't worry. There is no such thing as ocular. Wait, they come back 20, 30, 40, 50 years in a row, and they still are ocular. And then they're hit by a car and they die. And they say, oh, look, see, he was about to generalize. But he got hit by a car and he died, but there's no such. So I think that ocular myasthenia usually generalizes. I think to say there's no such thing is maybe a little much in my personal opinion. But I assume that you're talking about the difficulty with dysarthria and dysphagia and not ocular myasthenia. Those are more difficult cases, and that's going to require more aggressive treatment. So they may require some amount of prednisone, but for the patient who has prominent severe bulbar weakness with dysphagia or dysarthria, that's a patient that I think is more likely to need more aggressive treatment very quickly. Rituxan, I think, is a reasonable choice under those circumstances. I think that plasma exchange is worth considering. I think IVIG is worth considering. If they're seronegative, eculizumab is out and efgartigimod is out. Those would both be off-label indications. But for someone who has severe weakness of the bulbar musculature, dyspnea, dysarthria, dysphagia, you're going to have to go with aggressive treatment much more quickly.
Sure. I think we have time for maybe one or two more questions. Any help on how to treat relapse inactive COVID patients?
How to treat in the age of COVID. So that's an excellent question, especially because there's the thought that COVID causes some of the problem and the body's response to COVID causes some of the problems. So there's been some very, very preliminary data that suggests that people who are on immunosuppression under some circumstances might do better in some ways because they don't have that cytokine storm as much. In general, I am a little more worried about the B-cell depleters in patients who have myasthenia gravis, if there's any worry about COVID. The other thing to think about is if they're on Rituxan, and Ocrevus has run into this as well in the realm of multiple sclerosis, is that if patients are on one of those medicines, they might not mount the immune response to the vaccine. And that's why for Ocrevus, there's some advice as far as you may want to hold Ocrevus, get them vaccinated, and then start them back on Ocrevus once they've had that response. But in general, you're caught between a little bit of a rock and a hard place. We can't exactly say it's the age of COVID, don't treat your myasthenia. I'll see you back when you have myasthenic crisis, but at least you're not going to have COVID. You have to find a balance, and that's difficult, and we're in really an unprecedented stage. But I think it's a matter of finding that balance, and you go with the risk-benefit ratio. But it's the B-cell depleters that I might be a little more worried about in my myasthenic patients if there's a concern about COVID.
Thank you. And one last question, and this is for the sake of timekeeping here. Is there any value to testing further for more rare antibodies? You go for MuSK, LRP4. How far do you go?
So from my standpoint, I usually start with, well, let me back up. MuSK antibody patients tend to have severe bulbar onset symptoms. So anyone who looks like they have myasthenia gravis, I'm going to send for binding, blocking, modulating antibodies all the time. That's pretty much 100%. But if a patient that I see has obvious disproportionate bulbar onset, if they have that obvious dysphonia, if they have the obvious facial weakness early on, I would think about MuSK much more quickly. And I would be much more likely to send that with my first wave of testing. Now, if I get antibody testing for binding, blocking, modulating antibodies, and if it's negative, I will probably send for LRP and for MuSK testing. Other antibody testing is not available on a commercial basis. And I explain that to my patients as well, that the fact that you're seronegative doesn't mean that you don't have myasthenia gravis, it's that we can't prove it. I've had patients who I've managed to get research testing done in other areas. I had a patient who I looked at him and I said, I know this guy has facioscapulohumeral muscular dystrophy. And his genetic test came back negative. And I said, I don't care what the lab says. I know that this guy has FSH. And I wound up sending him up to University of Rochester and had Rabih Touil look at him and send the research tests and had them send it over to the Netherlands. And the research protocols, it came back positive. And we said, yes, there's no question he has FSH, even though the initial test was negative. but you have to be able to get the patient in with the research institution, and that's not so easy. So the other testing, it's just not really available right now, except under extraordinary circumstances if they went to a research institution that can test that, which is not generally done.
Dr. Lovitt, thank you. What a pleasure, very informative. And I think we have to invite you again to have the rest of those questions answered. So thank you again.
Thank you, sir.